But I think one of the myths that perpetuates the orgasm gap is this myth that women are more difficult, women take longer, like the hardware is somehow more complicated. Like it's just kind of perpetuating, like, don't worry about me this time. Like you do you. But if you look at women who masturbate, they orgasm at the exact same speed that men masturbate. So it's like the amazing myth buster of like, nah, the hardware seems to work when you know how to work the hardware.
It isn't about being perfect. It's about being better. Hello, my name is Dr. Stephanie Stima, and I host expert discussions with thought leaders in all facets of health, including nutrition, fitness, hormones, stress management, performance, recovery, longevity, health span, and energy production. On this show, we discuss complex science, but then we also alchemize it into actionable, everyday living. The ultimate goal with the show is to assist you in making informed decisions about your health and to catapult you into being the hero in your own life. Hello, my Betties. Do I have a treat for you today? My conversation is with Dr. Kelly Casperson. She is a world-renowned urologist specializing in empowering women to live their best lives. She too is a podcast host. It is called You Are Not Broken. And her forthcoming book, You Are Not Broken, Stop Shoulding All Over Your Sex Life, has been called one of the top 8 books for better sex by the New York Times. So what did Dr. Kelly Casperson and I speak about today? Well, we distinguish between good sex and bad sex. We talk about mercy sex, accepting pain, faking orgasms. We talk about how women get body confidence so that they can relax and get out of their minds and into their bodies. We talk about what PIV sex is, orgasms, the different types of orgasms, and how orgasms for females have been mislabeled by Freud and others. We talk about testosterone replacement therapy and what are some of the clinical numbers that we should be looking for in a perimenopausal or postmenopausal woman. And then we also talk about some of the genitourinary shifts in perimenopause. So urinary incontinence, pelvic floor prolapse, painful, poor lubrication, et cetera, et cetera. And we talk about how some of getting up multiple times overnight to go to the bathroom. So we talk about that, and we talk about the impact that hormones and declining testosterone, declining estrogen and progesterone have on the genitourinary system. This conversation is for every mother, every daughter, every son. Like I like to say, this podcast is for women and the men who love them. This is adult sex ed, as we said multiple times on the show. And I think that you are going to get so much value and remove a lot of the shame and the blame and the hurt that women so often carry around about our anatomy, about our function, about climaxing, about pleasure. It is absolutely required listening, again, for the women and the men who love them. So please enjoy my conversation with Dr. Kelly Casperson. Dr. Kelly Casperson, I am just tickled and delighted to welcome you to the Better Podcast. Welcome to the show.
Thanks for having me.
Your new book, You Are Not Broken, fantastic book, fantastic read, and very necessary because you attack and address a lot of the pain points in a woman's gynecological genitourinary journey, where she might be very scared, guilty, ashamed to discuss some of these things, and you really shine a light on it, which I think is so important.
Thank you.
Let's talk a little bit about what constitutes good sex, and let's contrast that with bad sex. So maybe we'll start with bad sex. What is bad sex?
Sex that is painful, and not painful in the good sexy way, because they're asterisks to those people, but painful sex, doing sex to control somebody else's behavior, which I see a crap ton of in long-term relationships. If I don't have sex, he's going to get moody. He's going to get whiny. He's going to get blah, blah, blah. So sex to control another person's behavior. Sex that serves somebody else more than it serves you. Duty sex, it's a checklist, 8 fruits and vegetables.
Like, I'm a wife, so that therefore this is part of my to-do list kind of thing.
The unspoken contract that was signed. Certainly non-consensual sex, forced sex, coerced sex. But I mean, I see a lot just in my practice of like, I call it mushy broccoli sex, of like, people are like, I don't desire sex. And I'm like, well, is the sex you're having great? And they're like, no. And it's like, you can't work on desire. You can't desire mushy broccoli. You can't desire, shredded cold chicken for dinner for 35 years, right? Like for most people. Some people love that. But just sex where it's kind of, you're just going through the motions, and then you start thinking like, maybe am I asexual, which some people are, but statistically speaking, most are not. I would say more are having bad sex than are actually truly asexual. But women kind of they're like, what's the point? Like, sleep's better, and I never wrote a book to tell people to have sex, especially sex they don't want to have. Like, there's plenty of people that don't want it. But if you're in a relationship, it's a sexual relationship, and you want to work on personal growth, development in your relationship, like, this is an amazing topic because it brings up so much junk that we were socialized with, told as children, learned from our first boyfriend when we were 17. We just like carry it with us and never open up the lid and actually examine, like, is this sex life I'm having actually mine?
Oh, what a question. Is this sex life that I'm having actually mine? Oh, and we can dive into some of the health benefits of having a great sex life. You outline this a little bit in the book where you say good sex adds 20% to a relationship, whereas bad sex drains it by 50 to 70%.
I think that's Barry McCarthy, who's a really famous sex therapist, is like, a good relationship with good sex, the good sex adds a little bit. But a good relationship with like strained or bad sex can really destroy a relationship. And like, this is data I've been looking for because I'm talking to a lot of divorce lawyers at this age, because we're in the like, kids are getting grown, midlife, mid-career, menopause is happening, and the divorces start happening. And like, really researching what are the top reasons that people separate. And they always say sex and money. But I'm like, I'm getting from people I'm talking to, money's like a distant second. It's lack of intimacy and connection and like feeling the love. And sex plays an important part in that.
And so if you are listening to this right now, and maybe you're like, oh yeah, that's me. I'm having the cold shredded chicken, mushy broccoli sex, and we've been having it for the better part of 20 years, let's say. How do we move from having mushy broccoli sex to having great sex? Like, what are some of the characteristics of a nourishing relationship, sex life that where we're coming back for seconds and thirds?
Yeah, Peggy Kleinplatz wrote an amazing book called Magnificent Sex, where she actually researched the people who like raised their hand and they were like, I have good sex. And she's like, tell us about it, right? Like, how do you have great sex in your life? And nowhere in any of these experts was like spontaneous desire for sex one of the reasons they said they had a great sex life. I think so many women, they're stuck like, only if I desired it. And like, the experts are like, no, like, it's intentional, it's purposeful. We're willing to communicate. We're willing to try and fail. We're willing to feel vulnerability. Like, it's all of these like really adult topics that make for a great sex life. And I think, we get sold a bill of goods by the magazines and online of like, you just need the right vibrator or the right lube or the right, piece of lingerie of like, no, like that's fun. That's great. Those are shiny toys. But like, really doing the work of like, how do I want to feel? What feels great for my body? Like, maybe I've been doing the same thing and there's other things we could try. It's this like innate curiosity about the sport of sex, if you will.
And I think there's something about it, you were saying trial and error, trial and failure, being vulnerable. These are almost qualities that we forget as adults in many verticals. I mean, I see this in fitness and nutrition because this is the area that I tend to play in and counsel women around. And people are just used to what they're used to. And it's like, they would sometimes rather stay in their comfort zones rather than venture to the unknown. So I think that, what you're talking about here around being vulnerable, being curious is sort of putting maybe some of your preconceived beliefs, with sex and desire, of course, it's a loaded and very heavy, can be culturally specific topic as well, where we have sort of pre-fed ideas around what being sexual and sensual is as a woman. And of course, like I said, cultural specific. And for perimenopausal and menopausal women, which is the bulk of the listeners of the show, we're going to have a certain, growing up in North America and sort of seeing the cultural images that we have growing up, we're going to have sort of a certain ideal, let's say unspoken ideal around what a healthy sex looks like.
Yeah,
And
that's
you know,
right.
you mentioned something about like, oh, just like the lingerie. And it's like, you know, when you said that, I was like, yeah. And so many women won't even look at themselves, like won't even look at themselves in the lingerie, don't even know what their vulva looks like, you know? So one of the areas I maybe wanted to explore with you a little bit is in the context of good sex, when we're talking about being vulnerable, trial and error, where pleasure is a priority for both men and women, how can we I'm and maybe you can speak to this more than I, but how can we embody body confidence? How can we sort of feel good get out of our heads and into our bodies when we are engaging in sexual activity with our partners?
Yeah, I mean, talk about societal, constructs of like society tells us implicitly or explicitly who's allowed to be sexual, who's allowed to enjoy pleasure, what age, what level of body functioning, what body appearance, right? So we're really told because of the images that are thrown at us, like who's allowed to be sexual, the stigma of older people not being allowed to be sexual, and like it's all made up. It is all advertising, right? And really understanding, I love the body work and the body image stuff because so much of sex and being able to orgasm is really a letting go of thoughts. They take brains, they put them in MRI machines and they have an orgasm. And like the frontal lobe, so the thinking, criticizing, analyzing part of our brain literally goes dark during an orgasm. And so the work of judging, comparing, am I doing this right? Is the lighting okay? Or is my thighs jiggling? Like they call that spectatoring. But like it literally, by definition of the part of the brain you're using, is turning off the orgasm. And I think the other thing about body image is like nobody was born hating themselves. Society put that on you. Wherever it came from, it probably came from 10 different angles. But you were not born hating yourself. And when you can kind of take the lens and be like, I took on all of that crap so that I wouldn't be mean to myself, you can literally, start to middle finger it. And it might be a lot of work for some people. But some people, it's like a light switch of like, screw that. Like, I was not born hating this body. Let's go back to radical self-acceptance. The Body is Not an Apology by Sonia Renee Taylor is an amazing book. Because she's like, we're all just trying to be neutral, right? Like, let's just get neutral about our body. And she's like, how about we go radical self-love? Like maybe neutral's not enough, and I was just like
that. Oh. There's a quote that's like self-defined, like loving yourself is an act of defiance. I don't know who said it, but it's something like loving yourself is a radical act of defiance in, today's.
Yeah. I just saw something exactly. It was something that was like, if women decided today that they were enough and lovable as they were, like industries would crumble.
That's right. The luxury goods industry would crumble. Yes.
Yeah.
Makeup, all the things. Yeah.
Totally.
Yeah, totally. That's good. And you talk a little bit about this in the book in the beginning, which I really appreciated for it to be put in the beginning, because I think in order to have a conversation around good sex, you do need to address the elephant, so to speak, in the room, which is like perfectionism. And there's so many women, my Betties, we like our audience, we lovingly call them our Betties who listen to the Better podcast, but our Betties, those perfectionistic, those very high achieving, very, achievement oriented women who have taken on, who like to control everything in their lives and like to be able to predict, go through the algorithm, predict the outcome. That is wreaking havoc on your sex life because you are not able to enjoy. And as you're saying, like sort of fully sink into your body, turn the PFC, turn the prefrontal cortex, let it go dark so that you can actually get into the sensation, the somatic experience that sex might offer.
Yeah. It's really a place where time doesn't exist, right? Like it has to be, this is all like deep brain pleasure stuff of like, you're not keeping track of time. And if you are, then you're not enjoying the pleasure. And the other thing about sex, which is so funny, of like, it's supposed to be one of the most enjoyable, pleasurable things, right? Especially like we've got a lot of things that compete with dopamine now, but like 100 years ago from eternity, sex was like as good as enjoyment got. And we're always trying to rush it. We're like, how fast should it take? How long should this take? And it's like, we don't try to rush through like a nice meal. We don't try to rush through your favorite TV show. Like, we can't even enjoy the pleasure without like trying to make it go faster. It's very bizarre.
That's actually a very interesting observation. Let's just explore that for a moment, because I think that I've actually, just in the spirit of truth, and honesty and all of that, for my Betties to hopefully relate to me, or maybe I'm just going to make a fool of myself, but whatever. Sometimes, it takes a little bit longer, right? And you could, like, I have had those. I'm like, oh my God, it's been like 15, 20 minutes. It's like, isn't that long? Isn't he getting tired? Like, is all of those different things. So where does that come from? Because I love the word, I talk about this word a little bit. And maybe I talk about it because I'm trying to embrace it myself. But this idea of like savoring things, like I want to say, to your point, I want to savor a meal. I want to cherish time with my family. And then of course, when I'm with my husband, I want to savor and cherish, that time with him, whether it's sexual or sensual or not. So where does this urgency for time come from, especially when it's with respect to the female orgasm?
Yeah, no, it's crazy. I mean, I think it's part of society's just like time scarcity stress. Like I can sell stuff to you if I make you feel pressured, right? Like there's something to society and over scheduling. And like, look at our world. There's so many interesting things, right? If you literally don't be like, you're going to be overstrapped all the time. You can literally not sleep now because there's electricity and screens and like, it's crazy. And Netflix. And so like you literally have to, we live in a society that's going to over stress you and over schedule you unless you're very intentional about it. And I think sex just takes it gets in the way, because it's like sex is the opposite of go, 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 do it right, get it fast, drive through. Like it's kind of the opposite to it. And I guess in going back to your theme of like radically rebellious, of like, turn off the world for a while. Just enjoy being in a body. It's kind of badass then, I guess.
It's kind of badass. It's like, just enjoy being in your own meat sack for like, however it is. And you talk about this, this time to orgasm. I don't know if that's the official term, but I'm sort of thinking like, when we think about male time to orgasm versus female time to orgasm, it is very different, right? So, and we can talk
with
a little
penis
bit about
and vagina sex.
Yes.
But not with masturbation.
Okay, so let's distinguish between those. Let's talk a little bit about the difference in time to orgasm with what you call PIV sex.
Well, I think one of the myths that perpetuates the orgasm gap, which is most pronounced in a heterosexual relationship, the man orgasms about 98% of the time. The woman orgasms in a committed relationship about 60% of the time. Hookup sex is like 7% of the time.
Oh no.
It's
7?
Hookup sex is horrific for the female. I'm not sure why they're doing it besides performance and validation. They're not doing it for orgasm because we got data. But I think one of the myths that perpetuates the orgasm gap is this myth that women are more difficult, women take longer, like the hardware is somehow more complicated. Like it's just kind of perpetuating, like, don't worry about me this time. Like you do you. But if you look at women who masturbate, they orgasm at the exact same speed that men masturbate. So it's like the amazing myth buster of like, the hardware seems to work when you know how to work the hardware. But when you are in a heterosexual relationship and prioritizing PIV sex, which is penis and vagina, that is like the best way for a man to have an orgasm. Feels freaking fantastic. You can orgasm very fast that way. It's a very inefficient way for a woman to orgasm. So you pair those two together, and then she gets in, especially if you are believing the myth that sex ends when a man has an orgasm, right? How many times does that happen? So you're like, well, she didn't have an orgasm and he did, and I guess we're done. Good night.
No.
Right? And then she's like, I want to cry. I'm having mushy broccoli now. But it's like, we did, and this is why I call it adult sex ed, is like what you got was probably a disease and pregnancy prevention plan before you were an adult, before you were in a long-term relationship. And then you find yourself having mushy broccoli because you didn't get an adult sex education, right? We didn't prioritize talking about it. What does sex mean to you? What's the best way for you to orgasm? How do you like to orgasm? Right? Like we don't talk about these things. And then we're just like, well, I guess sex is meh for me. And it's like, no, you just didn't get the education.
There's so many ways I want to unpack this because I think, when I think about my sex ed, air quotes growing up, it was like the banana, it was like, this is how you put the condom on the banana. There was never any talk about, and it's maybe grade 9-ish, 10-ish, something like that. I think that, I don't know if that's still standard, if that's when sex ed starts. I know that in some schools they're starting that earlier, and that's sort of a different, maybe political conversation. But I do think that there is a lack, whether it's through the education system or just the general national dialogue around sexuality and pleasure, because we sort of get the anatomical, like penis and vagina, there's an ejaculation and then semen and then, fertilized, and then there's a pregnancy.
Right.
I grew up Roman Catholic, so the messaging, and this is not, it's just my experience. It could be different among other Catholics and other Christians, but it was just, don't get pregnant. Like, your number one job as a woman before you're married is not to get pregnant. And I actually recall when I was married and, we wanting to start a family, like, it literally felt like backwards land to me, because I'm like, I have spent 28 years not like trying not to get pregnant, or actually I had my first son 32. So 32 years, whatever it is, 31 years trying not to get pregnant. And now I'm supposed to just like get pregnant. Like, it just felt so
right. And then
now I'm allowed.
Like, it might take a while to get pregnant, and you're like, what the heck?
Yeah,
this is supposed
I was
to be
petrified.
Like,
yeah, and I'm like, oh, but I'm married, and we've been married for a couple of years, and that's what we want. But it was so bizarre for me, because that was sort of the encoding that I had, and I share this because I know that I'm not the only one, because I've had conversations with my girlfriends who've had like a variety of different upbringings that had the same kind of experience. Like, when it was time to get pregnant, it was like, really? Like, we're going to allow the semen in this time? Like, we're not going to wear a condom? We're not going to have the, not going to be on the pill, whatever it is. So yeah, I think that it's a trip. And I think that there needs to be a conversation around, well, maybe a broadening of what sex means, because to your point, this PIV sex, this penis and vagina sex, is not the only kind of sex. And as you were talking about with the orgasm gap, it is not the thing that for most women, the large majority of women, are going to orgasm from. And of course, obviously sex for reproduction and propagation of the species is very important. And it's also a really beautiful expression of your love for someone, right? And for you to share that with somebody. So why not teach him or her, to be able to please you in the way that, you like to be pleased. Like, we need to know, us as women, we need to know what feels good for us as well.
Yeah. We give away, unintentionally, we're not aware of this, we give away a lot of our power, right? Because we're like, dude, if you're heterosexual, the people you're with don't even have your hardware. Right. And then you're like, well, I didn't have an orgasm. Right. Like, I guess and it's like, they can't even practice. Right? They don't even have the same gear. And they didn't get a secret class. Right? And so, like, combine that with society's oppression on women of like, your body parts are vulgar, don't touch yourself, that's dirty. Right? So we don't empower women to understand their bodies. We don't empower them to even use the right words. And then we pair them with somebody who doesn't have the right body parts, and we think they should know. Right. And it's like, we're literally set up for being bad at understanding our pleasure because we didn't get the education. I think the other big trip, going on the like, don't get pregnant, is like, now you have perimenopause and menopause where pregnancy is completely off the table. And for these people, and that, by the way, that's 30 to 40% of your life is postmenopause now, because we're living so long. Right. And so those people are like, what sex if there isn't like a pregnancy to prevent or have? Right? Like, it's completely removed from it. Now what's sex for you if it's not preventing pregnancy or having pregnancy? And that's completely unexplored for most people.
And we got to love up on our men a little bit too, because our poor men are watching porn. Right? First of all, if you have sons, like, this is also, if you are a mother of sons or you are a man listening to this episode, we're not poo-pooing on men, but unfortunately, a lot of men get sort of what they think is going to please a woman. Like, we were saying this before we got started. It's like, she sees the head of the penis and she's screaming at the top of her lungs so the neighbors hear, and she's coming all over the place, right? And it's like, that's not how it works for women, So this depiction of, in porn, which is often, and I know there's more erotica now with female producers and things, but for generally the porn that men watch on Pornhub or wherever is this PIV sex, penis and vagina sex, and she's climaxing after, a minute or two, screaming her head off. And it's like, that's not how it really works in real life. So we already have our beautiful men who want to, if we're talking about just a heterosexual relationship, you want to assume the best of intentions about them. They want to please their partner, but they don't know any better.
They really do. They really, the majority, and again, stereotypes are useful and not useful, but by and large, men want you to like sex.
Yeah.
They really that's part of your partner's enjoyment, is understanding that you're enjoying it. Right. And again, nobody gets taught sex ed. Nobody knows this. But a lot of porn, 1/3 to 40% of the internet's bandwidth is porn viewing.
Wow.
Like it's we were like, porn. Like it's video over internet was literally created at the speed it was created to get pornographic images across. Like this is how ubiquitous it is. And if we don't do a good job with sex education and educating our young sons and daughters, they're going to get an education from what's literally a movie. It's a production. Right. There's fake stuff. There's fake liquids. There's fake orgasms. Like they're watching a movie. That the best image is like learning how to drive by watching The Fast and the Furious. Is like, that's not driving. That's a performance.
And then the car is jumping across buildings.
Yeah, it's going over
somehow
dumpsters.
Survives.
That's not how it works. But you hear this, especially on the college campuses, of the men coming in and being like, I'm broken because my penis doesn't work like that. Or I'm not having the experiences that I'm watching on the videos, and I'm realizing it's fake. And plus, you're not taught how to communicate, and that bodies don't always perform 100% of the time, right? It's all that, again, adult sex ed of that's a performance, bro.
Bro, yeah. If my teenagers were listening, it's that Riz is mid, it's like that charisma, which is apparently Riz. That's what Riz means. It's like charisma. It's that's mid Riz. Okay, so let's talk a little bit about how we orgasm. I was saying to you in the pre-chat, it's we got to talk about clitoral versus vaginal orgasms, which was sort of a myth propagated, as you correctly said before we got started, by Freud, that you sort of have these immature orgasms that are clitoral, from the clitoris, and then a more, air quotes, mature orgasm is going to come from the vagina. Let's talk about why that is not the case. And maybe, we can talk a little bit about anatomical homologs as well, why some women can orgasm from penetrative sex. And that might be just sort of the extension, or because there's some friction with nerve endings that are associated with the clitoris.
Yeah. So, I mean, Freud messed us up, man. Freud said that libido is like an innate drive. It's not for everybody. You will die if you don't sleep, drink water, or have food. You will die. Those are innate drives to survive. The species will die off if you don't have sex, but you are not going to die off if you don't have sex. You don't need it to live, right? And so Freud was very wrong in saying libido is an innate drive, like thirst. It's no, it's not. But look where that got us. Everybody feels bad because they're not wanting sex all the time. And we can go into you need sex for a lot of women. You need sexual context, right? It's not good to just want to have sex at work all the time. There's appropriate places. So Freud said, and this is again the male gaze of what works best for a man is to put his penis in a vagina, right? So isn't it nice to tell women that putting something in your vagina is how things are supposed to go? The clitoris, in thinking about homologs, we all start out with the exact same anatomy, and then at about 10 weeks as an embryo, we differentiate into stereotypically male and female, although there are variations. And the penis is the clitoris. Clitoris is the penis. It's the same thing. Now, through the penis runs your urethra, so you pee through it, and then also the ejaculatory duct, so you can put semen through it. The point is, the penis has 3 jobs: peeing, propagating seed, and pleasure. And the clitoris has 1 job. It's strictly pleasure. And now the clitoris is thought of as this little pea that sits above where you urinate out of, but that's just the head of the clitoris, which is the same as the glands of the penis, or the tip of the penis. So it's literally the tip of the iceberg. Very, very important for pleasure. Sometimes it's so sensitive and so intense that you actually have to, touch around it. Some women don't like it right on top. And then the clitoris actually breaks around like a wishbone to go around the vulva and around the vagina. And that's why vulvar touch and vibration, and for some people, vaginal touch, pressure, fullness, vibration feels so good. Now, there are other nerves that go to the brain for the orgasm. We've got pelvic nerve, pudendal nerve. And that's why some women say, around the cervix feels really, really great for me. Some women can orgasm with nipple stimulation, right? So there are truly a lot of different nerve pathways that can go up to the brain for orgasm. And what the research is showing now is the more nerve pathways, like the more highways you have running at the same time for pleasure, the more intensely the orgasm is experienced. And where this comes in, I think, is kind of bringing in all of the the people are like, it's just the clitoris. That's the only thing that orgasms. And then you've got the other camp who's like, there's 17 different types of orgasm, and you're like, how do you marry those two different kind of teachings? It is like your organ of pleasure is the clitoris. And if you activate other pelvic nerves and nipple, breast nerves, some people ear, right? There's lots of different pathways. The more you activate at the same time, the more intensely it's felt in the brain because you have more superhighways going on. And that's what you can play with. You can play with like one little area of pleasure. You can play with stimulating the whole pelvis, maybe back around the perineum, maybe the buttocks, maybe deep, right? Of like play with there's lots of different nerves, but by and large, the penis is the clitoris.
So that's really awesome to know that there's that homologue. And also, some of the things that at least we see case reports of this when women go in for plastic surgery. I don't know the exact name, but it's like labioplasty, maybe, where they're going in for cosmetic. I don't,
trimming.
Opinions aside, yeah, but it's they're improving, subjectively improving the appearance of the labia. Also reporting afterwards numbness and lack of a decreased pleasure, let's say. So we don't even really know. You've been describing a little bit like the erogenous, like nipples and earlobes and, glutes and all these different places where the more sort of highways, the more stimulus, let's say, you have to the brain. But there's been, at least I've read a couple of case reports just in prepping for this and other conversations that I've had where these surgeries, these plastic surgeries are now, they're reporting different sensations, different pleasure, or like a decreased pleasure, let's say during sex, which is so unfortunate. And we can talk about the politics of improving the vulva. I think every vulva looks a little different, and that's all beautiful. But if you decide to go and alter it, also know that you might also be clipping some of those pleasure, like those nerves that are looping back to the brain.
Yeah. So the labia minora is erectile tissue, right? We think of penises having erections. Women's pelvis also fill with blood and become erect and have erectile tissue, meaning with pleasure sensations, blood flows in, right? And that helps the nerves, that helps prevent trauma, it helps protect the tissues, it feels amazing, right? Because we all have the same body parts, just rearranged in different ways. So the labia minora are incredibly erogenous, very sensitive, lovely for pleasure. They can get numb if you do surgery on them. It's like if you do surgery on your elbow can get numb. You're cutting nerves. I think one of the problems and I'm a pelvic surgeon, so I feel like I get to have an opinion on this. But when our body parts are banned, when we can't learn what normal is, when we don't get taught anatomy, we are left to be preyed upon by curated images, by doctors saying this is what ideal looks like, right? Like our uneducation makes us prey to feeling like our body isn't standard, or our body needs to be changed, or our body needs to, look a different way. Because where are you going to go on the internet as an 18-year-old girl to know if you look normal? It's very hard. Instagram doesn't even let us say the body parts. So we are literally in the dark and then preyed upon because everybody will take your money. Everybody will take your money. Except for the people who are like, you know what? If it doesn't hurt, like there are some and we can get into this. There are some labia that are, because of their length, they get pulled into the vagina. It's difficult to ride a bike. It chafes with, exercise wear. Like there's some legitimate medical concerns, but by and large, we're chasing a false ideal. We're taking people's money, and there's risk with that. Now,
Yeah.
the side of the I'll asterisk, just to be the devil's advocate, is there is a profound effect on sexuality by your view of your body image. And we know this. How well you feel like you fit into the ideal female or male affects your body image and how much pleasure you deem worthy of having. So some people say, I got the surgery, my body image is awesome, sex is great now. Like, it helps some people. But to me, I'm like, we just need the education to understand all of this. And then I do believe women can make the right decisions for themselves.
And my first question would be, do you know what it looks like already? Have you taken a hand mirror or something? Because the vast majority of women, I'm sure that you might have, more experience than I in this realm in terms of having these conversations, but most women don't even know what they look like. They won't even look at themselves.
Yeah.
Right? But
I had a woman and she was like, I'm thinking of getting a labiaplasty because I think my labia is really showing my age. And I'm like, do people ask you how old you are? And you're like, hold on, let me check my labia.
Like, this little labia, this labia is like 56. That's what I'm going with.
Like, don't check your age by what your labia looks like. And I think the other thing, I saw a woman and she's like, I was doing a physical exam and she's like, oh, don't look. It's really bad down there. And I'm like, what do you mean? Because I'm always curious. I'm always like, what's that mean? Right. Yeah. And her husband was with her. And she's like, oh, well, my ex-husband told me that my labia was like basically awful. Right. And I'm like, listen, I look at like 10 labia a day. Like, I'll just draw on the bell curve where your labia is for you. And I was like, this is like such a normal labia. It's like forgettable, right? Like, in your doctor's office, like you forget the normal things. And the husband's like, see, honey, I told you. I've been telling you all these years.
I want to cry for her.
And
she's been taking that around with her everywhere.
Yes,
that she's like some abnormal freak.
Yeah. She like decides to believe the jerky ex-husband.
Yeah.
And I'm just like, dude, you're so wonderful. You're just wonderfully average. Like, congratulations, stop carrying that dude around in your head.
Yeah.
So yeah. Gosh. But yeah, it's like, and for me to hear that more and more states are restricting anatomy education is like, do you think this is going to get better?
What is that all about? You were telling me about Florida. What is happening with Florida? What is going on there?
So apparently from the research, because I haven't like posted any of this on my platform yet, because I'm like, I really want to understand this before I go off and say like, oh my God, what's happening? But apparently the state board of education is really limiting what teachers can teach. So they're removing consent discussions of like domestic abuse and like how to deal with that, anatomy education. So like a lot of stuff that's just healthy for teenagers to know is being removed. And what we need now is not less education.
Yeah, I have so many questions about that. Like, what is the thinking behind the benefit? Because you don't make a decision like that without thinking that's going to benefit your citizens in some way.
Yeah.
So they're either trying to protect them against something.
I think there's a big concern about porn use and like wanting to kind of first of all, good luck getting rid of porn. Like, it's 1/3 of the internet.
That's not going to change if you don't discuss it.
And not like, for me, I would be like, teach children that it's a movie. That it's not how adults actually have sex. Like, educate them on the fact that it's not real.
Or at least find some porn that a woman has produced. If we're going to go the porn route, which I don't recommend, and I'm not recommending, for the record, please don't write in and tell me I'm not recommending porn, but at least find some other examples of representation of sex, maybe from a woman, or maybe some erotica, like some erotic book. Like, there's other, maybe not I know that's not the visual piece of it, but there's other ways that we can look at sexuality, like different perspectives on sexuality.
Yeah. To me, it's just throwing out the baby with the bathwater is like to decrease body knowledge, anatomy knowledge, communication, how to communicate about this stuff. Like, we suck at communicating about sex. Like, not talking about it is not going to make that any better.
Yeah. Yeah. I got to agree. I got to think about why. So whenever I hear something like that to me seems that it's not the right decision, somebody has thought this through and said, this is the right decision for our kids. So
Right.
I appreciate that you haven't actually posted about it yet because you're trying to really fully understand it. That would be my
Yeah,
inclination.
to me, I'm
why
like,
are
it
they
sounds
thinking like that?
too crazy
Yeah.
for me to like just jump on.
Yeah.
But yeah, apparently there's one state written manual in Florida. And I'm like, can somebody get me this manual? Because basically they're like, you have to teach what's in this manual or otherwise you can't teach anything. And so I'm like, who's got the manual that I can read?
Yeah.
But we do know, I mean, there is the Guttmacher Institute that says sex ed in our country today is worse than it was in the 1990s.
Wow.
Yeah. So if you think you got a good sex ed, it's worse now. And I don't think many Gen Xers are like, mine was the only people who say they've got amazing sex ed is people who are like, my mom sat me down. My mom, blah, blah, blah. And nobody's like, I wish my mom didn't do that. Like everybody's so incredibly grateful, any gender. Everybody's so incredibly grateful that they had a mom who's like, this is your body. This is how it works. Pleasure is good. You got your pleasures as important as your partner's. Like, God bless the moms that do that.
Yeah.
I'm sure there's some good dads that are doing it too, I'm sure. But by and large, the stories I hear are moms.
From moms. Yeah. And this is part of the reason why I think that this podcast is going to be so important, because there's a lot of moms listening, mothers to daughters, mothers to sons, that can really, this is sort of like a grassroots, sort of like a grassroots uprising. Like if the school isn't going to do it, if they're going to ban it, or they're going to just do what I experienced, which is like, here's the banana, here's the condom, this is how you put on the condom.
Right.
This is the menstrual cycle. And it's like, they didn't even explain it. It's like you bleed and then, you ovulate. And then that was like a week of that, maybe even, if a week. And then that was it. Everyone was uncomfortable, including the teacher.
Totally. And I see that. I mean, I see the lack of menstrual cycle education coming to bite us now in perimenopause.
Oh yeah.
Because, I see so many women who the week before their period in perimenopause is literal hell. And it's like, I'm like on the weekly drawing out like, this is why, because your estrogen plummets. And, and so it's like, dude, I'm going back to like body education 101 in perimenopause because people have no idea what's happening in perimenopause.
Yeah. And this idea of like body literacy or even hormone literacy, menstrual literacy is so important. So I have women, who've picked up my book. I know who will pick up your book and they'll say, wow, I'm 40 and I never thought to pay attention to my cycle. Isn't that crazy? And it's like, yeah, that is crazy. And that's why I wrote the book. And that's why I know you wrote the book, because you want people to have literacy over how they're different, how that hormonal landscape changes, that flux of hormones, as you were just describing. So
yeah, when women are like, I didn't know so many women couldn't orgasm by putting something in their vagina. I thought I was broken. Right. And I'm like, that's why I wrote this book.
Yeah.
Because you just feel profoundly broken when you just didn't get the education. You give them the education and they're like, oh, well, that's just not the way the body works. Like, it's like such a relief to just get some basic education.
Yeah. Let's talk a little bit about some of the changes that happen in perimenopause. You outline this in the book, the genitourinary shifts that happen in perimenopause. And maybe we can talk a little bit, you spend some time talking about HSDD, but maybe we can talk, before we even get there, let's talk about some of the hormonal shifts that we see in perimenopause and specifically how those might begin to contribute to libido changes. And of course, libido and desire. It's not just hormones, right? There's like a biopsychosocial sort of element to it. Mm-hmm. But if we're just looking at it from a mechanistic or maybe more of a hormonal perspective, what are some of the shifts that a woman can expect in perimenopause so that she doesn't misinterpret her experience when she gets there and thinks that she's broken?
Yes, totally. So 3 hormones that are important. We have many hormones, but 3 like commercially available hormones, which is why we tend to talk about them more in women, is testosterone, progesterone, and estrogen. Testosterone's your highest in your 20s. It kind of does a linear decline, so it doesn't really hit a wall or drop off at the end of periods. It just starts going down after your 20s, kind of linearly. That one is stereotypically the libido hormone. Not always. Estrogen's a great libido drug too. But testosterone's stereotypically the libido one. So I see a lot of low testosterone in perimenopause. The big myth about periods is that when your periods stop, then you're allowed to have hormones, or somehow your periods are a marker of now your hormones are low enough, instead of your periods are a consequence of what happens with low hormones. And why this is important is because so many women they go to their doctor and they're like, I'm having hot flashes, I can't sleep, I'm having pain with sex, I'm having dryness, my bladder's starting to want to pee all the time. And the doctor's like, well, you're still having periods, so there's nothing wrong with you. Right. And it's like, really understand the hormones are going nuts in perimenopause, because it's like it's reverse puberty is one way people talk about it, because they're like, puberty's ovaries coming online, perimenopause is ovaries going offline. Right. And so periods are just like an end marker of the hormones being enough to cycle. So what you're experiencing in perimenopause is real and can be treated. And this myth of like, you have to wait for your periods to stop is like not grounded in any sort of science. It's just kind of an arbitrary made up. And plus 1/3 of women have had ablations, IUDs, or hysterectomies. Like they don't even have periods to mark when they can have hormones. So it's kind of arbitrary to like stick the bleeding people on like, sorry, you got to wait. It's like, she didn't have to. But so genital urinary syndrome of menopause is the profound hormone changes that happen in the pelvis. And you have to go back to be like, estrogen's not just hot flashes and like the ability to get pregnant. Of like, estrogen and estrogen receptors are everywhere in our body, from inner ear to eyeball to the gums in your teeth to your brain to your clitoris, your vagina, your bladder, like your labia minora are very hormone sensitive. So the biggest way to like get women to perk up is to be like, your labia minora can go away after menopause because you don't have enough hormones to like keep your labia. And women are like, oh, what? And you're like, oh, now you're paying attention. Like, now you care. Okay, nice. But I didn't get taught that in med school. Like I had to go to the International Society for the Study of Women's Sexual Health, and they're like showing pictures of, vulvas after menopause. And I'm like, oh, it is odd that the women who I thought were born without labia are all 70.
Talk a little bit about, I laugh not because it's funny, but because I'm shocked that this is not being screamed from the mountaintops. Like I'll pull this stat from your book, and then I'll have you go into it, because literally I had to pick my jaw off the floor. So from your book, You Are Not Broken. Without hormones, vulvovaginal atrophy happens in 50 to 80% of women, and it gets worse the longer that you go without hormones.
That's true. Multiple studies.
That is wild.
The thing about it getting worse is very interesting, right? Because I'll make up an age. I'll see a 66-year-old. Yeah. And she's having recurrent urinary tract infections, getting up 3 times a night to pee, hasn't had sex in 5 years because it hurts so freaking much. Like, she has GSM, right? And I'm like, well, this is a hormone change. And she has no idea, because she's like, I stopped having my period 10 years ago. And you're like, yeah. Not having hormones continuously starts affecting you more and more and more, right? Like, why do you think osteoporosis is at its worst when you're 80, right? It's 30 years without hormones. And I think that's why this, perimenopause and menopause movement of like educating the Gen Xers, who, by the way, are the oldest Gen Xers are turning 60 next year, is like the decisions we make now as far as hormones and health, we're setting up being 70, being 80. And, for GSM, the treatment's local vaginal estrogen, low dose. It's basically like skincare. It's super cheap. And, the experts were like, we think about it as a preventative medicine. Because I'm like, what would you rather do? Would you rather just start a vaginal estrogen cream when you're 55? Or wait till you have urinary tract infections or wearing pads, have stopped having sex? Like, why are we waiting for you?
And your urologist thinks you were born without labia.
Yeah. Unless you got like, my own time and money of getting the education that I have now, because we didn't get taught this. But it's like, why wait for you to break when the prevention is so safe and so cheap? There's a study looking at if you gave every woman of Medicare age vaginal estrogen, you would save like $1.2 billion a year just in reduced urinary tract infection costs in this country.
Wow.
So it's like really it's, Western medicine sucks at prevention. How many women do I see where they're like, they told me I wasn't sick enough. They told me it wasn't bad enough yet. It's like, we really have to shift like prevention instead of waiting for you to break and then trying to put you on it.
Yeah, there's no ICD code for almost, it's like you have to qualify for the diagnosis, and which is the unfortunate sort of system of healthcare. But I wanted to talk to you a little bit about this, about vaginal estrogen, because this is I think a source of confusion, because people don't understand that this is a local dose of estrogen to the vagina and the pelvic area versus systemic estrogen. So let's maybe talk about the differences between those two. And then we can maybe even further elaborate in terms of, I get this question a lot, I'm sure you do as well, around estrogen risks, right? So taking isn't this going to give me a heart attack and breast cancer, right?
Yep.
So let's talk a little bit about systemic versus local application of estrogen.
Yep. So systemic means full body. And you can give yourself full body hormones by swallowing a pill. You can inject it. You can wear a patch. You can do a gel like on your arm. And what matters is what the dose is, right? That the dose is high enough to actually get into your bloodstream and be in your body. And so you take a local vaginal estrogen cream. So it comes in creams, pills, and rings. The cheapest is the cream. I have a cream bias because I like getting it on the clitoris and labia because I like to preserve function. But super cheap, super low dose. So if you start yourself on some vaginal estrogen and then you check your blood estradiol levels in a couple of weeks, it's not going to be any higher. You can actually test it, right? And so it's like skincare, which we know is like a $6 billion industry, putting cream on your face. It's like, it's just,
ladies, if you're
cream
putting
down
vitamin
there.
C and retinol on your, you're spending however much on retinol or vitamin C or whatever potions and lotions for your face, like we can put some vaginal cream. We can put some cream on our vaginas, our vulvas, and in the vagina.
Totally. There's non-hormonal moisturizers as well. I think those are wonderful. I don't think they're unsafe. I think you should use both. And so like the non-hormonal vaginal moisturizers are like, you're just putting moisture on dry skin. Whereas the estrogen cream's actually improving the quality of your skin.
Like olive oil? Is that what you mean? Like,
oh, like, no, there's like a lot of products. Like a lot of products have like hyaluronic acid and they kind of just hold in moisture. You can get a vaginal suppository or like a balm and creams and stuff like that.
But we want to do that and have the maybe also preserving function and collagen. And one of the terrifying things I read in your book was that over time, and I think I'm going to get this wrong anatomically, so redirect me here, but I think you would, without estrogen in and around the vagina, I believe the hood of the clitoris it gets stick onto or like affix itself to the clitoris itself.
Yeah. So think of like if you're putting on a turtleneck and the turtleneck gets stuck over your head, that's clitoral phimosis.
That was the word. Yeah. Clitoral phimosis. That is petrifying.
Yeah. And it's super common. Petrifying.
Yeah.
And like stereotypically, sometimes it'll cause pain, right? Because if you're like walking around with a stuck turtleneck, like it kind of pulls. So it can be pain for some people, but for other people, it's a decreased ability to orgasm because you're basically like have an extra layer of skin on top of your sexual organ. So women will be like, oh, it just takes a lot longer. Or I feel like I'm trying to like work through a quilt, just to have decreased ability to have pleasure and orgasm. So very common. It's just most doctors aren't even trained to look at vulva. I always joke the gynecologists who are, for 22,000 doctors, that's how many gynecologists there are in America, there's 80 million women over the age of 40. We cannot rely just on gynecologists for all of women's healthcare. The stereotype needs to end. They're too busy already. But like the joke for them is like the vulva is just the curtains to get to the cervix. Right. But yeah, to be actually taught how to do a good genital exam is like, it takes a while. You need training. I see so many women who are like, I've been told it's just normal down there. I'm like, no, honey, that's not normal. No wonder why it burns every time that you pee.
Can we as patients also do a self-exam? Like, how they talk to us about, scanning the breast day 1, 2, and 3 of your period for any lumps and bumps. Is there something that we can be doing for our vulvas and our vaginas as well?
For me, it's like, just get to know your body, know what it looks like. Because I see so many people, they're like, I found a lump down there. And I'm like, that's your urethra. And because we get out the mirror and we look and like, what are you looking at? And I'm like, you got to know what normal is, because if you look for the first time, like you might not know what all that stuff is. And this is very hard nowadays with the 10-minute doctor appointment. This is where like the concierge, the people who actually spend an hour with you, this is where they shine, because they can actually have the time to take a mirror, teach you your anatomy, show you where all the parts are. It's invaluable and doesn't exist in a 10-minute once-a-year visit.
And shame cannot exist there, right? It's like if the doctor's saying you are the most normal of normal labias, and this is completely how you, shame has no opportunity to have its, sometimes devastating effects and hold on you, right?
Yeah.
When we can understand, like that's why education is really powerful here.
Yeah. I think Brene Brown said that. She's like, shame doesn't exist in sunshine. Of
Oh, yeah,
shining, when you shine the light on something, shame goes away. Like it loves being under the covers.
Yeah. Let's talk a little bit about urinary incontinence. I had Dr. Suzanne Gilbert-Lenz on the show. Yeah, she's awesome.
I love her.
And she was talking about urinary incontinence as well. And this is, again, another, shining the sunlight on the shame. Let's talk a little bit about what that is, what that looks like, how that might progress for a woman. You'd mentioned it a little bit already when we were, talking about, having to get up multiple times in the night to go. What does urinary incontinence look like, and how does it clinically present, and then how does it progress over time, and is there anything we can do about it?
Yeah. So by what we mean by incontinence is unwanted bladder leakage, urine that comes out when you're not sitting on the toilet, right? Women will be like, I don't have incontinence, I just leak. I'm like, okay, we got to explain what incontinence is. Right, so bladder leakage, there's two main types. There's stress incontinence and urge incontinence. So stress incontinence is your stereotypical laugh, sneeze, cough, trampoline, running. Any sort of, what they mean by stress is force, right? So any sort of force on the pelvis.
Squatting sometimes.
Jump rope.
A lot of women are so scared to squat or deadlift because of the internal pressure. Yeah.
And that's anything in the pelvis that's not offering support anymore. So low hormones have decreased collagen. Low hormones can have decreased muscle strength. We know we start losing our muscle mass after age 30. So hand grip strength is associated with bladder leakage or not bladder leakage. So just how much muscle mass we have. The stretching and the shift in the pelvis with childbirth, vaginal more than C-section. So that's stress incontinence tends to be a structural problem. Physical therapy works great. And there's this new thing called Bulkamid, which I love. It's basically everybody knows what filler is now. And I'm like, filler, it's filler for your urethra. It just gives you a little more volume to decrease the leakage when you cough, sneeze, laugh. 5-minute procedure.
That's cool.
It's very cool. It's keeping a lot of mesh out of pelvises because the mesh sling has been like the bread and butter for stress incontinence as far as surgical treatments. But the pelvic floor physical therapists are amazing, and they help a lot of people with bladder leakage. It's non-surgical. There's no.
What about Kegels? Where do Kegels fill in there? Like I would give a lot of patients in practice hypopressives, especially. Well, I would deal with post-pregnancy, like diastasis recta. When the abdomen is separated during pregnancy. So hypopressives because the patient's not able to actually contract the muscles because that makes it worse. Kegels, hypopressives, are these helping at all to improve the internal mechanical structure?
Yeah. So Kegels are basically a pelvic floor contraction. Yeah. You got to do a lot of them. Like it's not like do Kegels once and you'll never leak again. Yeah. It's like it has to be a consistent practice so that they're like every time you're at a red light when you're driving, anytime there's a commercial on. Like it's something that will trigger you to actually do your pelvic floor.
They have exercises. Apps too. They have apps where you can it'll sort of send you a reminder and it'll say hold for 10 seconds. And I have one on my phone. I can't remember the name of it now. But
there's a bunch of them. There's a bunch of Kegel trainers for at home. I think just long term people don't tend to stick with them, in my experience. But that's why I like the pelvic floor PTs, because they teach so much about anatomy, and they know how does your pelvic floor and your core, what's your hip injury doing for all of this? How's your low back pain tied in, right? Like they're so comprehensive, and like the home of the pelvic floor, they're just invaluable. And then urge incontinence is more bladder leakage with that overactive bladder. So the stereotypical is like leak with running water, leak with the key in the door, leak on the way to the toilet. Urgency,
because they can't hold it. They can't hold it long enough to get to the toilet.
Yeah. Urgency, frequency, getting up at night, feeling like you always got to go. I just went, but I feel like I got to go again. So like urgency. And a lot of that is hormone changes. Vaginal estrogens. I tell people, I'm like, it's medicine for your bladder, but we put it in your vagina because your vagina and your bladder share a wall.
Yeah. That's a great way
of
putting
it. There's great data to show how good vaginal estrogen is for overactive bladder. The bladder has estrogen receptors, and the structural like bladder muscle changes when estrogen goes down.
And I wonder also about the ligamentous attachment of the bladder. When you've had a multiparous woman, someone who's had 3, 4, 5, however many pregnancies, two or one or more really, how those ligaments are affected. The baby stretches everything out, all the organs move around. And I wonder if the estrogen also can help with that ligamentous attachment too. Like, sometimes we see pelvic organ, we see POP or, pelvic organ prolapse in women who've given birth. I wonder if that vaginal estrogen can also be helping with the attachment of the bladder to the abdominal wall.
Yeah.
Well.
I mean, my theory on that is that the vaginal estrogen is probably too low of dose to actually get in and affect ligaments. But that's where the question of what's the role of systemic hormones in prevention of pelvic organ prolapse? I have not seen a great study, mostly because it takes a while to develop pelvic organ prolapse, right? You're going to have to put women on for a while, but they can probably do a observational study. Now they have enough data. But for me, I'm like, yeah, hormones are invaluable with we always think bones and muscle, but it's like the disc space in our spine, super estrogen dependent, and disc compression, right? Ligaments, cartilage, joints. That's all very hormone mediated. And we know the rate of issues with that goes up post-menopause if you're not on hormones.
All right, so let's talk about HSDD now. So we've sort of talked about the landscape of perimenopause in terms of the hormonal changes, some of the common changes that many women might experience, vulvovaginal atrophy and some of the urinary incontinence and et cetera. And now let's layer on hyposexual or sexual desire disorder. Your book, you talk about the highest prevalence of HSDD were women aged 40 to 60 who were partnered, who are educated and taking psychotropic medication. So maybe we can define a psychotropic medication for the audience, just in case they're not familiar. And then let's talk about what constitutes HSDD.
Yeah. So psychotropics, antidepressants, anti-anxiety, things to regulate mood.
Yep.
In America, we take the most of any country. In America, 25% of midlife women are on an antidepressant. It's in
25, did you say? 25?
Very high. Yeah, I think that's an age like 60, 65.
Nuts.
It's very, very high, which, by the way, there's a bone fracture risk with these drugs. No woman's ever told that.
Oh, yeah.
There's like meta-analyses on this. And I'm not
trying to get off them. Try to get
off
them.
I mean, that's the thing. And I don't want to, break the internet by saying all drugs are bad. I'm not saying that. What I'm saying is women need informed consent about options and understand that these medications are very hard to get off, and they do independently increase your risk of bone fracture, which in a world where 1 in 3 women are going to have a bone fracture is a big deal. But I mean, the other thing that I think why I harp on it so much is like a lot of perimenopause and postmenopause symptoms are treated incorrectly with antidepressants instead of hormones or other things. Yeah. So I do believe that 25% of women, I think that's a very high level to be on this medication. And you look at the rate of hormone prescription going down after 2002 with the WHI, and you literally there's graphs of this. Hormone prescriptions go down, anti-anxieties and antidepressants go up. So I'm I'm just reporting the data and saying why don't we think about this? So HSDD is basically I had a great sex life. I used to love sex. I have a great partner. This is independent of there being a psychosocial issue going on, right? I've got a great relationship, very well supported, used to love sex. And now I'm and not only am I even when we get into it and we start being in a sexual context, I'm still it's the brain is just not being turned on by it. And so we're it makes sense that if there are medications that can cause sexual side effects, then there are medications that can improve sex. And that's where the medications for HSDD come in. So to wrap that up with a bow, antidepressants cause sexual side effects about 40 to 50% of the time. Very, very common. And then there are medications that actually increase dopamine in the brain and increase desire for sex. And those are the two. We have 2 currently FDA-approved medications for low desire for premenopausal women, although rumor has it, hang on menopausal women, it's coming. But I always say your insurance company's not going to come to your house and be do you have pads in your closet? They don't know that you're postmenopausal.
But what would be the difference? And maybe I'm just too thick not to see this, but why would it only be for premenopausal women? What would be is it just the consideration of the sex hormones that are increasing the dopamine? What?
These medications work in postmenopausal women. It was put
Well, that's what I'm saying. Like that's
the line in the sand was put on arbitrarily by the FDA.
But why?
Because premenopausal and postmenopausal women are different species.
Yes.
No.
Yes.
No. I'm being tongue in cheek, but like,
no, of
it's
course.
completely made up.
We haven't even got to the horns yet, Kelly. Like the horns that grow in perimenopause.
Yeah. Like there's no safety issue with these medications once you hit age 52.
Yeah.
It's a complete arbitrary. I mean, the FDA is horrifically biased when it comes to women's sexual health. We've had Viagra on the market since 1998. After like 6 months of safety data, we have over 20 testosterone products for men with like 6-month safety data. And what they are requiring for women to get approved is not equal to what they're approving for men.
I have thoughts on that. I suspect that you do as well. Let's maybe talk about TRT, testosterone replacement therapy for women. But just before we do, I had one more question about HSDD. So we were talking about low desire and these medications that have been improved in just the premenopausal, the women without the horns yet. Of course, that's a joke, but of course, premenopausal women. Is there if someone is experiencing low desire, could we look at nutritional deficiencies, magnesium, maybe she's chronically stressed, vitamin D, iron? Like, are there other things that can explain why she might have low desire?
Oh yeah. I mean, HSDD is very specific, right? Like HSDD is not all low desire. And even the HSDD people will be like, dude, are you sleeping? Like, do you exercise? Yeah. Do you see some sunshine? Do you have joy otherwise in your life? Mm-hmm. Right? Like, how's the relationship? There's this amazing paper. Like I should get paid by this paper at this point. It's called The Heteronormative Theory of Low Desire in Women Partnered with Men. Lori Brotto and Sari Van Anders are two of the big authors on it. It is impressive. And the amount of women who, I actually have it like on my link tree because it's free on the internet. The amount of women who are like, I feel seen, right? And they're like, there's the specific social construct of women being partnered with men decreases women's desire. They did this amazing study on bisexual women, looking specifically at orgasm. When she's partnered with a man, she orgasms like 60% of the time. And when she's partnered with a woman, it was like, 85% of the time or something. I'm like, you literally put a penis in the room and her pleasure goes down. Mm-hmm, but it's like, that's the social construct of like, whose pleasure is more important. But, looking at unequal distribution of work in the home, that she always has to respond to somebody else's request for sex. She doesn't actually understand what her own desire is because she's always just responding to somebody else's. How close she fits to societal's moving target of what a appropriately sexual woman is, right? Like, it's like all these things affect our desire.
Like, are you a slut or are you frigid?
Yes.
Those are the two options.
The other very interesting thing with that is like the desire mismatch in a couple of his level of interest in sex is normal.
Yeah.
And hers is too high or too low.
What? Say that one more time.
In a stereotypical heterosexual couple, her desire, whether it's too high or too low, is the problem. And
it's always compared to, right. Okay.
His is the default.
Right. Of
right.
course.
And like, you're just like, oh my God. So yeah, I mean, that's why I'm like, dude, adult sex ed is so empowering for people because you're like, sex doesn't exist in a bubble. I saw this woman and like, I know I did a crappy job because I work in an insurance-based doctor relationship where I have 10 minutes, but it's like, dude, she had 3 young kids, shift worker, rough relationship, and she came in for low libido. And it's like, I can't just put you on a drug for low libido without you understanding that your sex life doesn't exist in a bubble, because then you'll fail the medication and now you'll feel like a medication failure and that feels crappy too.
Yeah.
And it's like, that's why I'm usually like, dude, read the book and then we'll prescribe medications, because you got to understand the book just helps so many people. You don't need a medication then. But to name the 2 drugs that are FDA approved, just so people know, it's flibanserin and bremelanotide are the generics. Brand name is Addyi and Vyleesi.
Okay. Is that the little pink? Is that the
little
is that
pink
the
pills,
pink
Addyi
one? Yeah.
and
Okay.
flibanserin. So that's once a day, taken at night. Side effects are mild weight loss and excellent sleep. This is
Living her best
not
life.
bad. It takes a couple of months to kick in.
Yeah.
So you can't take it once and be like, let's go. Because it works on the brain to increase dopamine. It's not a blood flow drug. They call it the pink pill, kind of like Viagra's little blue pill, but it's not a blood flow drug. It's a dopamine drug.
It's a dopamine. And then so we're working on dopamine, and then are we also working on testosterone levels? Because we know the dopamine and testosterone have like a bi-direction, like one goes up, the other one goes up. So we're also working on testosterone elevating as well, I guess, as an indirect consequence of that.
Yeah. So I have not seen data that Vyleesi and Addyi increase testosterone, but testosterone is a second lever that we can use when we want to play with desire. Testosterone is, and again, you have to back up because women don't know this. Women have more testosterone in their body than estrogen.
Yes.
Women make estrogen via the testosterone pathway, right? And we just have 1/10 the dose of what men have. The other interesting thing to know, because I think it just helps blow women's minds on like hormones, is like a postmenopausal woman has less estrogen in her body than a man does.
Yeah.
And then they're
I
like,
don't think people fully appreciate that. Yeah.
They don't. I'll get a couple. I'll get like a couple in their 50s, and she's like miserable but worried about hormones, and I'm like, his estrogen's higher than yours right now. She's like, what?
Yeah. She's like, set me up.
Yeah. I've had this one. Her estrogen was literally 0. I got it to like 30 on a patch or something. And she feels freaking like so much better. Like her life is back. Right. And I'm like, congratulations. I gave you a male level estrogen and you're doing wonderful. Right.
Yeah.
This is small amounts of hormones. And that's why the experts, they don't like calling it hormone replacement therapy, because they're like, truly replacing would, when you're pregnant, your estrogen's like 2000.
Yeah.
These are all American values for any international listener. But yeah, it's like a little bit makes a world of difference. And to go back to your other question, hormones are incredibly safe. Incredibly safe.
So talk about the breast cancer. What is the breast cancer? Where does this persistent myth, why does this perseverate with breast cancer and HRT or HT maybe?
Hormone therapy. So the Women's Health Initiative was a $1 billion federally funded study looking at older women. And they're like, can we put these older women on hormones and see if we can decrease the risk of heart disease? That was what the study was, right? Before publication, it hit the press. And they said hormones cause breast cancer, strokes, and heart attacks. And 80% of women in this country were taken off their hormones. And that was 2002. So we're 22 years past. And just like fear sells, good news doesn't travel as far, right? The same study, when properly interpreted, showed that estrogen decreased the risk of breast cancer by 30%.
So shall we tell our audience about the sample size of the participants that, they were well beyond, it was like 10 years beyond menopause.
So average age.
Many were smokers, many were obese. Yeah.
Many already had cardiovascular disease.
Yeah.
So, they already had increased risk for breast cancer in general. And the study wasn't designed to look for risks of breast cancer. It was a secondary outcome. Average age was 63. So it's like the conversation that we're having is, hey, if I'm a 51-year-old woman with symptoms, is it safe to go on estrogen? It's a resounding hell yes, it's safe. It's like the WHI didn't even study those women. They needed sicker women because you can't have a 30-year study to study heart disease. You need heart disease to happen fast. So you got to pick older women. You got to pick sicker women. And they didn't want, everybody's going to know if you're on a placebo because estrogen works so well for hot flashes. So very few of them were actually symptomatic. They were past all the like hot flashes, night sweats, poor sleep part. So for a 50-year-old woman who's, having to quit her job over symptoms, to be denied hormones based upon a crappy study that didn't look at people like her is the misuse of scientific studies. And going back to the
tragedies,
it's one of the greatest tragedies. 100%. I mean, they've done studies looking at the increased risk of death in women, specifically women with hysterectomies who were not given hormones since the WHI. The projections are probably about 100,000 additional deaths just in that population from being denied hormones, because it decreases the risk of heart disease by 50%, depending upon your study, 30 to 50%. If men had a drug that increased their life expectancy, do you think they'd be on it? Like, it's called estrogen. It's insane. It's insane the positive data we have, and women are still being denied the body autonomy to request and be on hormones.
What about I hear this a lot too, is like you can get on it, but you can only be on it for like 5 years, and then you have to, so you got to choose the, 5 years to live your best life, and then you can,
right?
Do you hear that?
Not rooted in any science. Where it came from is it came from like everything comes from somewhere, right? Like that's sort of my innate, like, where did it come from? It came from the WHI when we're like, hormones are going to kill you. You can't be on them. But since you're suffering, I'll give you the littlest dose, but you have to stop in 5 years. That's where it came from. And now we're like, oh, well, the fear was overblown. The data was wrong. And we've got studies that women who have started on them and then stay on them, as long as your benefits outweigh your risks, they actually do better. And, I've seen these people. They're the 82-year-olds. So 20% of women in America snuck through. Their doctors knew hormones were good. They kept them on their hormones. So these are now like 82-year-olds, right? Boomers were turning 51 in 2002. So like one of my most popular podcast episodes is The Boomers Should Be Pissed, because they missed the window. Yeah. But I see these 82-year-olds who are on hormones, and I'm like, what do you think? And all of them are like, over my dead body, will you take these away? They're like, I think
Mary Claire says something like that. She's like, you will take estrogen from my cold, dead body.
It's what your body, I mean, it's fascinating, right? Because people are like, the whole natural thing of like, do you know what life expectancy was in the 1800s and every year prior to the 1800s?
Naturally. Yeah. 40, maybe 30.
Yeah.
I'm not sure.
The aristocratic men in England in the 16 and 17. So the best of the best, the healthiest of the healthiest with the most resources and who didn't die in childbirth, 42.
Wow. Yeah.
Right. Like for people to be like, oh, estrogen's not natural. It's like, no, 92 is not natural.
Yeah. Taking a shower, using deodorant, brushing your teeth.
I have 2 vibrators for my mouth.
Yeah. All that's technically not natural either.
Man, but a water pick is so good for your gums. We're going to do it.
Totally. Yeah.
So, I mean, it's so fun to like challenge dogma with facts and education, It's like, the cars aren't natural. Right? Like, why are we picking our one natural as something our body
listening to this show
makes?
on iTunes is not
natural. You and me not being in the same town having a conversation right now, totally not natural. This is magic.
Yeah, this is a bit of magic. Yeah.
But yesterday, just to like, the tide is turning, even though I know I live in a bubble because I do this for a living. But yesterday I saw 2 women. Why are you here? Because I turned 50. Why are you here? Because I turned 51.
Good girls.
Like, yes. Like, I'm just like, dude, rock on. I'm like, what do you want? What do you care about? What are how's your mom aging? My mom's got osteoporosis. Okay. So your biggest risk is freaking osteoporosis. Let's have a bone plan. Right. Like they're the best people to take care of.
Those are like dream patients.
Oh yeah. I had a good day yesterday.
Yeah, I love that.
Oh, but I did. I had one lady who asked, she's like, can I use vaginal estrogen more than twice a week? Because the standard dose is twice a week.
Yeah.
And I'm like, yeah, like how much do you want it? It's like face cream, right? Like, how much you want it daily? I'll write you for daily. It's like so low dose. She's like, I asked my doctor. My doctor said I was a drug seeker.
Wow.
I know. It broke my heart.
These labels.
I know.
God. Well, I'm so happy that she had the opportunity to have that conversation with you, because you took you had the opportunity to sort of, swoop in, if you will, and remove that label before that became part of her personality.
I know. Right? I'm like, honey, you can bathe in this.
Yeah. You want it in a bath? You want it in a shower gel?
Yeah. It's over the counter in multiple countries. You can just go on a trip and bring home a year's worth.
That's great. I want to ask you, we got onto TRT, and I know I want to respect your time, but I want to make sure that we get this question in, because I know that TRT is like a big topic. What is an ideal? So obviously we know that with menopause, we see this, catastrophic drop in our sex hormones down to like 1% of what they once were. You were saying before, you were saying to the wife, you have less estrogen than your husband does. When we're looking at, obviously we're looking for clinical resolution of symptoms, but with TRT, because there's no testosterone replacement therapy for women, because there's there's no female product yet. Oftentimes it's done
that's the key. Yet it's coming.
So it's off label. We're often using like 1/10 the dose of what is available for men. Mm-hmm. Is there a clinical target that you might have for testosterone if you're doing a blood draw, let's say, for a woman and obviously it's going to be, there's bioindividuality, but is there a general range of T that you're looking for, free T?
Yeah, it's a great question. So guidelines on libido, which is like the most published thing for testosterone replacement therapy in women, is, we don't diagnose based upon a low level, and we don't say you don't have it based upon a level. Like, we don't use levels to be like, you're worthy, or you have this diagnosis and stuff like that. I usually get a baseline testosterone just so that I know it's low. Like, there's some woman out there with high testosterone who's 48. I just haven't met her yet, right? She's not seeing me. So I just get a baseline so I know where you were. You have to get the liquid mass spectrometry lab, because if you do a standard male testosterone lab, it's not sensitive at really low doses. Okay. So that's number one, is our labs are goofy and not trained for low doses.
For women.
Yeah. Number two is the lab, depending upon your lab, will use a normal value, I say that in air quotes, based upon whatever study they've decided to pick and to use. So, for example, my lab says you're normal if you're all the way down to a testosterone of 3.
I've seen 0, by the way.
Yeah.
I've seen 0.
One is not normal. I would argue 3 is low, right? And so, to me, I'm like, I can't just tell you like 56, right, without explaining. My lab for women is going to tell them that they're high when they're right about 40, right? And to me, I'm like, I really see women start seeing improvement in cognition and libido and lean body mass in the high double digits. So 50 to 100, I will easily let a woman go up to 150 if she's feeling great and not having side effects. Most common side effects would be more hair growth where you want it, less hair growth where you don't want it, acne. So to me, when I see her back, so I'll start her on 1/10 the male dose.
Like you'll start to see hair loss, sort of male pattern, like along the temples. Maybe.
It really has to be high testosterone to start seeing that in the majority of women. And I think hair loss is complicated. It's multifactorial, and we just want to blame hormones, but a lot of it's not hormone mediated, or it's because you've had low estrogen for 8 years, right? And so I am not, for a physiologically dosed testosterone, I am not seeing hair loss.
So we're talking about 50 to 100 nanograms per deciliter.
Yep.
That's what we're talking. So Americans, nanogram per deciliter. For Canadians and Europeans, something like 2.8 millimoles per liter is about 50, up to 4.4.
Now you're very much impressing me. I always have to pull out the online calculator. But what I care about mostly is how she's doing.
Yeah.
How are you feeling? Do you like it? Are you seeing an
Okay.
improvement? So I'll see women, they'll come back at 130 and they're like, I love it. And I'm like, great. Are any side effects? No. Great. But you have to prepare them, because you're like, your lab says high because of how the labs are. So now when you go to doctors, if you see somebody, don't let them freak you out. But if you look at the studies on improvement for mood and cognition and all this stuff, it is in that higher physiologic range where you're seeing the improvement. But
that tracks though with men. Like often you'll see men really thrive like 700, 1200.
It does track. In the men's range, it's like 299 is low. So at like 301, you're not feeling much better.
Right.
So there's a lot of just education that goes in, and labs are goofy. And when did you check it after you dosed it? And I mean, for me, what's annoying to me is that so many women get supraphysiologic doses. They feel crappy, or they're like chasing a steroid high, or they got bad side effects because traditional medicine's failing hormone therapy. So people are spending. Again, there's people want to take your money. They will make you spend a lot more than you need to get to stuff. And to me, I'm like, 40 years in menopause, you guys. You shouldn't have to remortgage your house to pay for your hormones.
Yeah.
Like money matters.
One last question on the TRT, and this is something that I'm hearing. I don't know if I agree with it, but I want to ask you because I don't know how I feel about it, and I'd like your opinion on it. I know that there are some women. We were talking a little bit before about some of the changes, the genital urinary changes in menopause, where we see a little bit of clitoral atrophy. I am hearing women using testosterone directly on the testosterone directly on the clitoris, for obviously increased sexual pleasure, but also to help prevent atrophy. Is that something that is, I don't want to say backed by science, I don't know if there's any studies, but is that maybe something in clinical practice that you've seen to be a success in terms of helping with atrophy? If someone has anorgasmia, is that maybe an off-label way that we might use it, or is this just like hogwash?
Yeah, I mean, short answer, hogwash, but I have to explain that, right? Like there's nuances from all this stuff. But so it's like, I would want an exam, right? Like I would want an exam to be like, you have atrophy or not. We don't have great data. Like penises come in different sizes, clitorises come in different sizes, right? So it's like trying to achieve a certain size is kind of like a vanity metric. I don't think many women are doing that, but we don't have data to support that. To me, I'm like, did you fail estrogen first? And then if you're trying to get systemic levels, I just think it's goofy to need to apply your systemic testosterone on your clitoris.
Locally.
It's like my quad works just as well, right? It's like, but so I think it's a little unnecessary. There's no data just because there's no studies looking at like prevention of atrophy on hormone. Like we have a paucity of research on female sexual function, let alone testosterone in general. So I tend to be like, when women come in, if they're doing that, I'm like, do you like rubbing your clitoris with cream every day? Like rock on if you do. It's not the standard way to do hormone replacement therapy. But again, it can't how did we start giving men testosterone? A patch on their scrotum, right? Because genital tissues have tons of receptors. It soaks it in really, really good. And some women will take a local testosterone dose, just like a local vaginal estrogen dose, and do that. But even that, I have to check their levels because they'll suck it up and get systemic levels pretty easily on a local testosterone dose. So I think the long answer is like, there's nuance. What is she doing it for? What's her goal? What's her physical exam? But I would say most people who are giving women physiologic testosterone aren't doing it through a genital route.
This has just been such a fantastic conversation. I have to just reflect to you, like one of the things I really appreciate the most about you is your candor. You are it's like all out there. There's no shame. We're just going to talk about absolutely everything. And I think that this is how, kind of back to that original thought we had before, this is how we remove the shame when we can this adult ed that I think, it's like adult ed with Dr. Casperson. It's like, we're just going to teach everyone about their vulvas, their vaginas, about, heteronormative, preconceptions. And then of course, extending that to relationships that are not heteronormative. Thank you so much. I know this is going to be so valuable for my listeners. Tell people where they can get your book and where they can find out more about you and your practice.
Thank you. So my website is kellycaspersonmd.com. That's probably the one-stop shop for podcast, book. The clinic website's on there. I hang out on Instagram. That's my favorite social media. That's Kelly Casperson, MD.
Awesome. We will have all those as clickable links in the show notes. Dr. Casperson, it's just been a delight. Thank you so much.
Thanks for having me.
All right. I hope you enjoyed today's episode. And I must give you the obligatory legal and medical disclaimer here. This podcast, Better with Dr. Stephanie, is for general information only. And the advice, recommendations we discuss do not replace medicine, chiropractic, or any other primary healthcare provider's advice, treatment, or care. In the consumption of this podcast, there is no doctor-patient relationship that has been formed, and the use and implementation of the information discussed are at the sole discretion of the listener. The information and opinions shared on this podcast are not intended to be a substitute for primary care, diagnosis, or treatment. In other words, guys, be smart about this. Take it with a grain of salt. Take this information to your primary healthcare provider and have a discussion with him or her to make the best choice that is for you. Remember, I am a doctor, but I am not your doctor. And these conversations are meant for educational purposes only.